assignment coming up, a case study assignment is coming up. So I'm gonna go ahead and share my screen and then show you the DSM. I'll get back to you around 5 when my husband gets home from work. Here are the trauma and stressor related disorders. I highly recommend you familiarize yourself with the different compartments and components of the DSM. This really is going to be so foundational in your clinical work when you diagnose, especially when you're unsure of a client's presenting problems. Often in supervision, I will ask the therapist to pull up the DSM, and then we'll go through the different diagnostic criteria together. So please use this when you're doing your case study for the week. But I want to just point out some specific criteria that will differentiate between various trauma-related diagnoses. The first one, reactive attachment disorder, we're not going to be covering a case study with individual who meets the criteria for reactive attachment disorder, but I do want to highlight it today because I do think it's important. Is typically I've seen this diagnosis play out with kiddos that were in foster care or ones that were adopted. Now, you do not being adopted or being in foster care isn't necessarily an indicator of somebody meeting the criteria for reactive attachment disorder, but the premise is due to childhood trauma and an inability to attach to a primary caregiver at a really early age. They learn to not trust primary attachment figures, and so when they're older, they really act out and push away and have a hard time attaching to adults. So looking at some of the diagnostic criteria, it's a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers manifest in the following. The child rarely or minimally seeks comfort when distressed, rarely or minimally responds to comfort when distressed. And the reason for the symptom is because they've learned at a young age that a caregiver is not going to meet my needs. When you are a baby, there's a bunch of studies out there that will show when you're a baby, your affect is influenced by your primary caregiver's affect. So if the baby's smiling and the adult, the caregiver, doesn't match that affect, then the baby's affect actually will change. The baby smiles and the caregiver smiles, then the baby's affect is matched. I'll see if I can remember to put a video for those that are interested of a study that was done where kids that were in orphanages left to cry, and they realized that nobody was coming to meet my needs. They just stopped crying. And how the story goes is somebody was looking in at the orphanage and none of the babies were crying. And so the person that was observing is like, wow, they must be all happy, content babies. And then the person running the orphanage is like, actually, it couldn't be farther from the truth, is that they've learned no one's going to meet my needs, so why even try crying? And so as a young age, it's imperative that children get their emotional, physical needs met because they're so dependent on a caregiver. And so when they learn they can't do that, that's what's carried into adulthood and even adolescent, where they will push away caregivers. Now, the distressing thing for adults is, let's say you have a family that is trying to conceive and they can't, so they wind up adopting, or they wind up going into foster care. The adults have this expectation that the kid's going to be grateful and they're going to want the kid to love them and have this big happy family, come to find out that because of the trauma the kid experienced, the kid is hesitant to attach to the caregiver. And so a lot of times the parents take it personally, they're distressed, or they may even punish or get mad at the kid. And so a lot of work I've done is with kids that met the criteria for this diagnosis because they were in foster care or the parents were incarcerated or they were adopted. So a lot of the work involved me having to provide psychoeducation to the adults and to the families to understand what was happening. Now, working with kids on this level, in my opinion, requires a specialty. There are some modalities, which we're not going to cover in this class, but there are some specialized modalities that really focus on building the attachment and the relationship between the caregiver and the child. That, in my opinion, requires further certification and training, which is why we're not really going to touch on this class. But if this is something that you're interested in, let me know, and I can send you some more research and articles, and point you to the right direction if you want to get certified in helping with that um, population. But this is one of the trauma related disorders, the reactive attachment disorder. And so just kind of going down the DSM criteria if you're interested in learning more about this diagnosis. All right. Oh, the other thing to pay attention to is that it does not they don't usually meet the criteria for autism spectrum disorder. That's a different diagnosis in itself. Okay, the ones I do want to focus on are the ones that you will have probably more experience with in your office. And so we covered this last week, PTSD. I'm not going to go through the criteria again today because we already went through that last week. I want to focus on some of the other ones that you will encounter in your office. Scrolling down, so acute stress disorder. All right, acute stress disorder is very similar to PTSD, but the differential criteria is the duration. So let's go ahead and read some of the diagnostic criteria. A, exposure to actual threatened death, serious injury, or sexual violation. So here we see this is similar to PTSD. Directly experiencing the traumatic event, witnessing in person the event as it occurs to others, learning that the event occurred to a close family member, and experience repeated or extreme exposure to adverse details of the traumatic event. So this also applies to first responders, therapists that work with trauma, police officers directly exposed to child abuse. Now, this is what I was mentioning last week, is that this does not apply to exposure through electronic media television, meaning if you witness something traumatic on TV, as a standalone trauma, then you wouldn't meet the criteria for acute stress disorder or PTSD unless the exposure is work related. So let's say you are a first responder or an investigator and you have to watch an actual scene of a murder could take place, then that itself would be an indicator of exposure to actual or threatened death or injury. Okay, and then presence of 9 or more of the following symptoms from any of the 5 categories of intrusion, negative mood, disassociation, avoidance, and arousal. So when a client comes to you in your office, they're not going to say, I'm dissociating, or I have intrusive thoughts, or hypervigilance, hyperarousal. Your goal is to take their symptoms in layman's terms, meaning they're going to tell you, I just don't want to talk about it. We're going to interpret that into clinical language as avoidance. They're going to say, I just find myself spacing out, and I don't realize that I'm doing it, but then someone will say, hey, come back to earth. We're going to give that a clinical term is disassociation. Intrusion, how client is going to present that is, I just can't stop thinking about it, as that it just pops into my memory. That's an intrusive thoughts. And so it's learning the definition of these symptoms and being able to define them as the clients present it to us. So when you read your case studies, you're not going to see dissociation or avoidance. You're going to see the case being presented as if a client was actually presenting it through their words. And then you're going to put the diagnostic criteria label on it. So what I want to see you do when you meet the criteria is to say the actual criteria definition, so arousal, and then plug in the client symptoms so I can see that you have understanding of the diagnostic symptoms. Here it goes into more detail about the intrusion symptoms, so recurrent, involuntary, intrusive, distressing memories of the traumatic event. Pay attention to this because we do have a kiddo case study. In children, repetitive play may occur in which themes of aspect of the traumatic event are expressed. I had a client early on in my career that witnessed his dad being shot. I think he was 6 years old, and it was a result of gang violence. And so in his play with me, what he would do is before every session, he would take the daddy lion and the baby lion, he would put him on a hill that he made, and then we were engaged in play. And at the end of the session, he would take the daddy lion and the baby lion and then put him away. Another client I had, his dad, I had 2 siblings. They were ages 8 and 5, and they encountered probably the most horrific abuse I've ever seen in this profession, head to toe, covered in lacerations. It took them a month in the hospital to fully recover. They encountered extreme sexual abuse, physical abuse, neglect. And so in reenacting their play with me in therapy, what they would do is they would take, I think we used Toy Story actions. They would take Buzz Lightyear and they would put Buzz Lightyear in a fake jail and keep him there, and then continue their play with me. And this is just an example of kids reenacting what happened to them through play. If you have sexual abuse, reenacting that sexual abuse through their toys, or even drawing out things that have happened to them. So if you see kid, the repetitive play, and there are themes in it, that could be a criteria for the intrusive symptoms. So make sure you take note of that because this does play out in one of our case studies. Recurrent distressing dreams in which the content and affect of the dream are related to the event. Why this is important is a client could say that they've experienced trauma, and then you ask them, do you have any nightmares? And they say yes. It's important to make sure that they connect. What if and you ask further, tell me more about the nightmare. So I have a nightmare because I keep thinking I'm going to be chased by a lion, and it doesn't really have any relation to the trauma. Let's say their trauma didn't include being chased by the lion. Maybe their trauma was being sexually abused by their uncle. We need to make sure that they connect somehow. Now, we could interpret it and say, are you being chased by a lion subconsciously as you're trying to avoid your uncle? Maybe, but that's kind of a far stretch. Usually the intrusive distressing dreams are replaying aspects of the actual traumatic event in their dreams. So dissociative reactions, flashbacks in which the individual feels or acts as if the traumatic event were occurring. I had a client who I was treating, 16, and her and her brother were forced to do sexual acts with each other when they were little. The dad and the uncle would take them down to the basement, and he had this altar with candles and a Bible, like religious artifacts, a cross, and then the dad and uncle would force the sister and the brother to perform sexual acts on each other in the basement. So fast forward to when I was providing therapy with the client, even the mere mention of what happened to her, I would see her face just dissociate. She would look away. And you could tell when you're treating somebody what happens to their face expressions. It's like almost they leave. Even though they're physically present, they kind of check out. I was just treating somebody actually last week. I was, was it today, Monday? Yeah, last week I was seeing a client, and she's in her 30s, early 30s, and we're talking about a violent relationship she just left, abusive relationship. And I was talking to her about the most impactful situation that happened to her in this relationship, and I saw her just as she's talking to me, just something inside her, she just shuts down and she looks down and then she starts shaking. And what happens is when you're in this stage where you dissociate, she's having her body was telling her, or it felt like she was experiencing it. And so she wasn't present with me. I could tell that she was reliving this in the moment with me because she was dissociating. And the incident that she described to me was when she was raped by him. And so even the mere presence of that was causing the client to dissociate. What I do with clients that dissociate, the goal is to bring them back into the here and the now. Now, we have a whole section in this class about treatment and assessment. So I don't want to spend too much time talking about treatment. I want to focus this week on assessing. But just side note, when a client dissociates with me in session, that tells me that they don't feel safe. And so I get her to go back into the here and the now. So some grounding techniques, exercises that you do, which help the client to come back to reality so that their body and their brain knows that they're safe. Okay, going back into the intense or prolonged psychological distress or marked psychosocial reactions in response to the internal or external cues they symbolize. With going back to my client that was just recently got out of an abusive relationship, when she was, there's actually a bunch of them. I'm trying to pick the one that I want to talk about. When she was driving in a car, driving home from work, he actually drove up next to her in his motorcycle and started banging on her window to ask her to pull over. This was actually trying to leave the relationship, and that scared her. And so as we talked about therapy, she was mentioning a time when she was driving and just heard a motorcycle, and that sound of a motorcycle reminded her of the traumatic event. And so she had a panic attack in the car. Even though she wasn't in danger, it was the sound of a motorcycle. So that is a example of a prolonged psychological distress marked by an external cue. There's also internal cues too. Okay, so going back, I want you to read these on your own, but they really do mirror PTSD. But this is the difference, is that the duration piece. So the duration piece for acute stress disorder is 3 days to 1 month after the exposure. If the symptoms last more than 1 month, then the client meets the criteria for PTSD. Now, note, symptoms typically begin immediately after the trauma, but persistence for at least 3 days and up to a month if needed to meet the diagnostic criteria. Now, if you have a client that has experienced something traumatic, they will experience these trauma symptoms, these trauma reactions. And that is a normal response to an abnormal situation. Where it becomes clinically diagnosable is the significant impairment. Looking at how are the symptoms significantly impairing their social, occupational, and other areas of functioning. So if you're reading a case study and we're not seeing clinical impairments, then it could just be what they're experiencing is actually a normal reaction. Where it becomes diagnosable is the impairments in functioning. So some examples are impairments in functioning in social settings. They withdraw, they isolate, they stop going to church, whatever they're normally doing. Let's say if they have a normal social routine and they stop doing that. Let's say they can no longer function at work. They can no longer function at school. And it impairs them. That's where it's diagnosable and it becomes more pathological, where they should seek counseling to help them function. one thing to pay attention to when you're reading the DSM is there's a bunch, and use this resource when you create your presentations, when you do your group projects. You'll get a lot of information about the diagnosis in these sections in the DSM, but here you will see clinical presentations, you will see associated, so differential diagnosis here, you'll see prevalence, you'll see the development in the course, you'll see the prognosis factors, the culturally competence piece here, the differential diagnosis. So use this when you do your group project. Okay, the next diagnosis we're going to look at is adjustment disorder. A lot of clients that we see, especially over at the college, do meet the criteria for adjustment disorder. Let's dive into those. The first diagnostic criteria is the development or of emotion of behavioral symptoms in response to an identifiable stressor within 3 months of the onset of the stressor. So here we see that there is no trauma. So the diagnostic criteria for A is different than the diagnostic criteria for acute stress disorder and PTSD. They're not exposed to something traumatic. What they're exposed to is a stressor. What's a stressor? Leaving home and going to college, having a death in the family if it wasn't traumatic, losing your house, losing your job. Defining stressor really is at the hands of the client, but it's something that is causing them distress, not so much trauma. So I hope that makes sense. Okay. Going back to clinical impairments, functional impairments, the symptoms or behaviors are clinically significant and cause functional impairments. So marked distress that is out of proportion to the severity or intensity of the stressor, taking into account that the external context and culture factors that might influence the symptom severity and presentations. The DSM was created mainly by Western population. So looking at some cultural influences and cultural diversity influences that could influence what would we define as significantly impairments in social settings. Example, I can think of this. Let me think if I can see of a culturally. I might have to come back to that because I'm drawing a blank for now, but I do know I have some. So, okay, and then the stress-related disorder does not meet the criteria for another mental disorder. So if in your case studies, if you see when you're reading about a client, if they have a stressor, a house burning down could be traumatic or it could be a stressor, but it's looking at the stressor within the context of how it's presented in the case study, loss of a job, having to move, a divorce, that could be a stressor. So that is the definition for adjustment disorders. Next one, the symptoms do not represent normal bereavement. So a death of a parent, a death of a loved one, if they are going through the natural grief process, that would be a normal response to a abnormal stress or grief and loss, not so much a identifiable stressor. Okay, I feel like I'm confusing. Let me think of, actually, guys. I might need to go back up to this. I need a second to think of a example. So looking at the symptoms do not represent normal bereavement. So an example I have of this is working with a female whose husband passed away, and she, going through the normal stages of bereavement, sad, and we have a whole section of grief and loss in here, but sad, withdrawal, feeling hopeless. Where it falls into the adjustment disorder is our marked distress that is out of proportion to the severity or intensity of the stressor. So with this client, even though it was sad and traumatic that her husband passed away, she was having a hard time adjusting, as evidenced by just absolutely refusing to get out of her bed, absolutely refusing to eat, didn't allow anybody to come into her house, just completely paralyzed, not able to function. So that's what this means. This does not represent normal bereavement. Is when you go through bereavement, you will have a natural response to it, which can resemble some mood disorders, anxiety, could resemble even depression, it could resemble even PTSD symptoms, but it's looking at the impairments in functioning, and that is out of proportion to the severity of the stressor. And so with this client, it's looking at the symptoms and being able to really weave through the behaviors and symptoms to help understand what disorder does this client meet the criteria for. Okay, there are some specifiers here for adjustment disorder. It's with depressed mood. This is if the marked distress out of the stressor comes with depression symptoms, low mood, tearfulness, feelings of hopelessness, or another stressor is anxiety, nervousness, worry, jitterness, or it could be mixed anxiety and mood with the disturbance of conduct. This is especially true with kids, with children. They tend to show us through their behaviors or conduct and irritability, with mixed disturbance in emotions or mood, or there is just unspecified. The one thing here to point out is this: once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. The key here is the occurring within 3 months of the stressor and does not persist for more than 6 months. Thing to point out here is once the stressor or its consequences have terminated. Now, this is kind of tricky, but an example of a diagnosed adjustment disorder that would be longer than 6 months is working with kids in foster care. So working with kids in foster care, it's common that their stressor is that they're not in their home, that they are in foster care. Now, let's say I worked with a kid whose parents were trying to get reunification and get him back, and they were having visits. And then all of a sudden the parents stopped having visits with them. Well, that's an additional stressor. Let's say the kid, for whatever reason, got bounced from foster home to foster home, and the duration of this was longer than 6 months. Then they would meet the criteria for adjustment disorder, even though it was longer than 6 months, because the stressor was still present. And so the key is once the stressor or the consequences have terminated, the stressors do not persist for more than 6 months. So if the stress or the consequences is still present and the client has a hard time functioning, it's impairing their functioning, how this will look with kiddos is refusing to go to school, a decrease in academic performance, an increase in conduct, an increase in moods, depression, anxiety, then they will still meet the criteria for adjustment disorder. Okay. Going down, let's see, I think I covered, and then we're not going to use this disorder, unspecified trauma and stress disorder, in this class. We're not going to cover DID. So looking at the ones that we are going to cover, just to recap, we have acute stress disorder, we have PTSD, we have adjustment disorder, acute stress disorder, and PTSD. And then the other diagnosis, and it's not so much a DSM diagnosis, more so helps to understand what's happening, is going to be the vicarious trauma, compassion fatigue. It still falls under the PTSD umbrella, but the subcategory would be vicarious trauma, which we will talk about in the vicarious trauma class. Okay, that is it for this week's lecture. And if you guys have any questions, as always, let me know. All right. All right, class. Week 6. Week 6. So